Hello and welcome. Today we're diving into a fascinating yet sometimes complex condition affecting the urinary system, duplicated ureter. Join us as we explore what it is, why it happens, how it's diagnosed, and what treatment options are available. So, what causes a duplicated ureter? Essentially, it's a birth defect, meaning it's something a person is born with. During fetal development, the ureteric bud, which eventually forms the ureter, splits or branches prematurely. Instead of one ureter developing to drain the kidney, two ureters develop either partially or completely. The exact trigger for this split is still being researched, but genetic factors likely play a role. Let's talk about how duplicated ureters affect the body. Normally, each kidney has one ureter that carries urine to the bladder. With a duplicated ureter, things can get complicated. One or both of the duplicated ureters may insert into the bladder at an abnormal location. Sometimes, one ureter might insert outside the bladder entirely, into the urethra vagina in females, or even the vas deferens or seminal vesicle in males. These abnormal insertions can lead to a variety of problems, including vesicoreteral reflux, where urine flows backward from the bladder into the kidney, urinary tract infections, incontinence, and even kidney damage. Duplicated ureter is a relatively common congenital anomaly of the urinary tract. It's estimated to occur in approximately 0.8% of the population. It is more prevalent in females than in males, and is often detected in childhood due to the increased likelihood of urinary tract infections. While many cases are asymptomatic and go unnoticed, others present with noticeable symptoms prompting medical evaluation. The signs and symptoms of duplicated ureter can vary depending on the specific anatomy and location of the ureteral insertion. Some individuals may experience no symptoms at all. However, common symptoms include recurrent urinary tract infections, daytime or nighttime wetting, incontinency, flank or abdominal pain, and in some cases, the presence of a palpable abdominal mass. In females, continuous dribbling of urine despite normal voiding may be a telltale sign of an ectopic ureter inserting outside the bladder. Diagnosing duplicated ureter typically involves a combination of imaging studies. Ultrasound is often the first line of investigation, particularly in children. It can help visualize the kidneys and ureters, though may not always clearly delineate the duplication. Avoiding cystoarthrogram, the FUG can identify vesicoreteral reflux. Further investigations like a CT urogram or MR urogram may be necessary to fully define the anatomy of the duplicated ureters and their insertion points. A MIG-3 renal scan can assess the function of each kidney and detect any obstruction. Duplicated ureters can be classified based on whether the duplication is complete or incomplete. Incomplete duplication, also called bifid ureter, is when the two ureters join together before entering the bladder. Complete duplication occurs when each ureter enters the bladder separately. Furthermore, the Weigert-Meyer rule often applies to complete duplications. This rule states that the ureter draining the upper pole of the kidney inserts ectopically, usually lower and more medially than the ureter draining the lower pole, and is more prone to obstruction and ureterocele formation. The lower pole ureter typically inserts in a more normal position, but is more likely to reflux. Treatment for duplicated ureter depends on the severity of symptoms and the specific anatomical abnormalities. Asymptomatic cases may require no treatment other than observation. For those with recurrent UTIs or incontinence, antibiotics may be prescribed. Surgical interventions are often necessary to correct the anatomical problems. Options include ureteral reimplantation, repositioning the ureter into the bladder, ureterostomy, adjoining the two ureters together, heminephrectomy, removing the portion of the kidney drained by the problematic ureter, or, in severe cases, nephrectomy and removal of the entire kidney. The choice of surgical procedure is tailored to the individual's specific anatomy and the extent of kidney damage. Unfortunately, duplicated ureter being a congenital condition, there is no specific way to prevent its occurrence. Prenatal care and genetic counseling may be helpful for families with a history of urinary tract anomalies, but they cannot prevent the development of duplicated ureters. The prognosis for individuals with duplicated ureter is generally good, especially with early diagnosis and appropriate management. Surgical correction is often successful in resolving symptoms and preventing long-term kidney damage. Ongoing research continues to refine surgical techniques and improve diagnostic methods. Minimally invasive approaches are becoming increasingly common, leading to faster recovery times and reduced complications. Newer imaging modalities also help in more precise anatomical delineation. The focus remains on early detection, personalized treatment strategies, and ultimately, preserving renal function and improving the quality of life for those affected by this condition.